Mogal. I'm Harveshp Mogal. I'm one of the surgeons here at Fred Hutch and UW. I direct the HIPEC program, and I co-lead the HIPEC Multi-D Clinic along with Dr. Stacey Cohen. I have another one of my partners, Dr. Sharib, here joining us, who also is part of planning this process, this webinar. Welcome to all of you. I know we have a bunch of folks that are still trickling in, so we'll give it maybe another minute or so, and then we'll go ahead and start. All right, we can go ahead and get started. We have a few participants that have already joined. Well, welcome everybody. This is our third annual High Five to HIPEC event that we put on every year at Fred Hutch and UW Cancer Center. Ever since we started the HIPEC program, especially the multidisciplinary clinic, we've had requests from several of our patients as well as communities to have an educational event just because of the rarity of the cancers we treat, the advanced nature of the tumors, and the lack of information that's out there, especially when it comes to updates and additional information over the past years in terms of additional research and things like that. And so we thought putting on an educational event would be beneficial for patients, and we were right. We've had an increasing number of people join these webinars every year, and we're happy to put them on. So thank you to all those that registered, and welcome to all of you who have already joined. As a reminder, we have a few speakers today. This is a webinar format, so you won't be able to ask your questions directly to us, but please feel free to type questions into the chat, and folks will be able to respond to those questions as and when they arise. The event is going to be recorded, so for those that registered and could not attend in person live, we will be able to access the link and see the webinar later. If you accidentally get kicked out of Zoom, because we all know that technology is not perfect, then please feel free to rejoin by using the link that was provided to you in the event details, that the email that you received. And then please don't forget to fill out the feedback form at the end of this webinar. We really rely on your feedback to improve this educational session every single year. And we want to hear from you about what worked well, what didn't, and what you'd like see us to put on in the following years. So do not forget to send us your feedback. We really value and want to act upon it. All right. So we have a few talks today. Some of our experts will discuss multidisciplinary care within HIPEC. This year we focused on appendix and colon cancers particularly, but obviously some of this applies to other peritoneal diseases also. Like we discussed, please feel free to ask questions. We have an impressive lineup of speakers. I hope everybody enjoys the webinar today and finds something that's educational for everybody. And with that, I'm gonna go ahead and proceed with our first speaker, Dr. Jeremy Sharib. Dr. Sharib is a surgical oncologist by training who did his residency at University of California in San Francisco, did a research fellowship at that time, and then trained in complex general surgical oncology at Duke University Medical Center. He joined the faculty at UW and Fred Hutch about 2 years ago now and has been an integral member of our multidisciplinary team. He will be talking to us today about what is HIPEC and other forms of regional therapy like PIPAC.
Sorry, I need to stop my share for a moment because I couldn't find my unmute button. But can I get a confirmation from the panelists that we can see the slides? All right, perfect. Thank you, Harveshp, and thank you very much for everyone who's attending today for allowing me to speak. We're really excited to have this patient education event as we had in the last couple of years, and hope that we can provide some answers to a lot of questions, as well as just bring up any new thoughts that might be out there. My job today, I really want to just give it a background and introduction of what is HIPEC, and to a lesser extent, some of the other newer modalities that are coming out for intraperitoneal therapy. I'll try to keep it as basic as possible. There's going to be some data coming up behind it, so hopefully this will just be more informative for all the people in attendance. My overall plan for today is basically to give a very brief indication or very brief background of what the indications for HIPEC may be, just to discuss overall the concept of peritoneal metastasis, and then give a little bit more of a technical aspects of the HIPEC procedure and the PIPAC procedure, which you'll learn a little bit about in just a few minutes. So the theme of the day is the management of advanced appendiceal as well as colorectal cancers. And we can see from this recent study from the SEER database, which is supposed to be a representative sample of all cancers diagnosed in the United States over the course of the time logged. But over the last 10 or so years, appendiceal cancer is actually the highest growing incidence for all GI cancers. It grew about 15 times in incidence over that period within this database. And colorectal cancer is also growing relatively fast as well, nearly doubling over the past decade. And this is particularly true for the so-called early onset cancers, which affect people less than 50 years old. But we actually see this increase across all age groups as well. So it's certainly an important diagnosis or important group of diagnoses. And peritoneal metastasis within advanced cancers of the colon or appendix are important because about 50% of people may experience spread of their disease over the time course. And in colon cancer, about a quarter to a third of people will have a type of visceral metastases, so something in the liver or in the lungs. But a pretty large percentage will also have potentially peritoneal disease, and so that's kind of the focus for today. This is a smaller amount than appendiceal cancers we'll see in the next slide, but the numbers are very large. And in contrast to colon and appendix cancer, not many people will have the visceral metastases, we call them, the spread of disease to the lung or liver, but nearly everyone who does have spread their disease will see something in the peritoneal cavity. So certainly the ability to treat peritoneal disease is really important for these two cancers, and their incidence is growing rapidly. While the exact mechanism of peritoneal spread is not completely understood, the old kind of thought was here on the bottom right or the bottom left, we see that maybe the appendix might have perforated and some of the cells that had cancer in them might have spread to the abdominal cavity. But abdominal spread can actually occur with or without perforation of the actual primary tumor. But even so, it's still considered a local or direct spread of tumor cells. And there does seem to be this kind of peritoneal transport, which we call the redistribution principle, which has a higher propensity for disease in certain areas. And that's kind of under the diaphragm on the right upper quadrant. This is the liver here, so just above that. In what's called the omentum, which is kind of like an apron of fatty tissue that kind of covers all of the intestines, and then in the pelvis. So when we look at some of the pictures and the surgical techniques, this will be important to consider. So once either appendix cancer or colon cancer is diagnosed, we do use several tools to stage and further evaluate the cancer. This includes axial imaging, such as CT scan or MRI, blood-based tumor markers, endoscopic evaluation, such as colonoscopy. And while we do a pretty good job of looking for any sort of spread to the liver and the lungs with these studies, axial imaging can only see about 2/3 to 3/4 of any peritoneal disease at the time of diagnosis. So the incidence of this can be underestimated or even missed. And so for this reason, if peritoneal disease is suspected from some more subtle CT findings, primary diagnostic evaluation will almost always include what's called a diagnostic laparoscopy, in which a camera is inserted into the abdomen to gain a direct videoscopic view of the peritoneal cavity. And if we see anything, take biopsies and also determine whether or not this would be removable. All the disease will be removable. And that's conveyed to within our group or to each other with something called a PCI score, which I'll talk about briefly in the next slide. Once peritoneal disease is established, if we see it either on CT or on our laparoscopy, nearly all patients with either appendiceal or colon cancers will receive systemic therapy prior to consideration of surgical resection. You'll hear more about this from Dr. Mogal and Dr. Cohen in the next couple talks. As I mentioned, the PCI score, just briefly, is really a mechanism of conveying within specialists the extent of disease, but also the pattern of distribution. So for this score, we divide the abdominal cavity into a 3x3 grid. This includes the abdominal wall as well as the organs below. And we score each point from 0 to 3 based on how much tumor may be present in that area. And then we also divide the small intestine in 4 parts. And we use the same 0 to 3 score for those components as well. So there's 13 total areas which we score. And so you can have a score of 0 to 39, and that indicates both the extent of disease as well as the overall pattern. So now for the procedure itself, first of all, it's important to note that in order for there to be any benefit from such an aggressive treatment, the goal of the procedure is really to remove all sites of visible disease based on our evaluation from laparoscopy and imaging. We also like to see that patients have stability or response to chemotherapy. And of course, they need to be fit enough to undergo a big operation and make it through. So, kind of overall doing well is really important. The cytoreduction procedure is kind of the first step. So this is the removal of any tumor that may be present. And this is tailored to each individual patient based on the pattern of disease. But broadly, it includes what we call stripping of the peritoneal lining from all areas where it may be present. So a couple examples here. This is the abdominal wall being retracted back with some surgical retractors. And these clamps are on this tissue paper thin abdominal wall lining called the peritoneum. We see that there's some disease on there, and we're stripping that lining off of the kind of thicker abdominal wall, and that's done above the liver in this picture, kind of above the diaphragm over the stomach here. And it's also done in the pelvis. And there are organs that kind of live behind the abdominal wall lining, such as in this case, the uterus and the ovaries. And as part of the procedure, if they're involved in disease, they would be removed as well. We also do an omentectomy as a standard part of the procedure, which again is that kind of apron of fatty tissue that lies over the abdominal organs. This is a common site of disease, but even if it isn't, there can be occult or kind of hidden disease, microscopic disease there about a third of the time. So we remove that routinely. And then we take a good assessment of the entire abdomen, and any other organs that may be involved could get removed as well. I mentioned it's a tailored procedure, so for limited disease, it can be a relatively short. This phase is very variable. It can be relatively short in the matter of just a few hours. But if there's extensive disease, as we see in the lower pictures here, it can certainly take 8, 10, even 12 hours to do this part of the operation. It can involve connections or anastomoses between multiple segments of bowel. It can also involve ostomy creation in some instances. When we're done with the cytoreduction part, we assess what's called the completeness of cytoreduction score, the CCS. And again, I mentioned our goal for optimal cytoreduction is to have no visible tumor remaining, so to remove everything. But because of the kind of properties of HIPEC and certain histologies that you'll hear more about in the next couple talks, there is on occasion the ability to have CC1 or kind of the vast majority of the tumor removed, but maybe small microscopic to kind of quarter centimeter disease remaining in certain areas that are going to be high risk to try to remove that disease. What we want to avoid is leaving large amount of disease. And in that case, the procedure may not add as much benefit. And so we try to figure that out before offering people the operation. So once the cytoreduction is complete, the second phase of the procedure is started, and that's the HIPEC portion, heated intraperitoneal chemotherapy. At this time, we close the abdominal wall temporarily. We place 2 perfusion circuits in there, one to bring the medication that will eventually come into the abdomen. We circulate it kind of manually by manipulating the abdomen itself. And then the second cannula is to remove the fluid from the abdomen. And it's connected to a circuit externally that kind of heats the fluid and keeps it moving, kind of like a cardiac bypass type of system. The medication we use for colorectal and appendiceal cancer is mitomycin C. And that's because of, it's an older drug, but it's because of some of the properties of penetration that it has into the tissue of the peritoneal cavity, and also the ability for it to have increased efficacy at a higher temperature. We use a flow rate of about a liter per minute. And overall, there's about 3 to 4 liters of perfusate running in the system at any time. The idea behind the HIPEC portion is that by giving chemotherapy directly to the peritoneal cavity, we can give higher doses than we could through the systemic system. And so you can get a really high concentration directly on the tumor cells. And also we have the ability to use medications that aren't really tolerated well systemically, like mitomycin. And this is done with really minimal systemic absorption. Again, the heat potentiates some of the tumor killing effect, and then the heat and the drugs also have direct effect on the cells. One other newer technology, just to kind of mention, and I know that Dr. Cohen will also mention a little bit about it later, is another method for delivery of chemotherapy into the abdominal cavity, and this is called pressurized intraperitoneal chemotherapy, or PIPAC. This was invented, kind of developed in Germany, and has been used in Europe for a number of years. But essentially, the idea here is that it's more of a minimally invasive type procedure. You have 2 ports which are placed into the abdominal cavity. One is mainly just to take a look and keep an eye on the catheter and all the other organs. And then there's this aerosolizer pen that's inserted into another area of the abdomen. This is a picture of it over here, but there's a couple different companies that make this now. And high pressure aerosolized chemotherapy gas is essentially pumped into the abdomen. And the idea there being that there's kind of a well-distributed flow of that gas throughout the abdominal cavity. And again, similar to a fluid phase, can get into all the little nooks and crannies and cover all the surfaces of the abdomen. In the United States currently, this is being studied across a small consortium of centers as an early phase clinical trial to prove that basically that it's both safe and that we can see some early efficacy. And while we don't have this here at Hutch at this moment, we are working with this consortium, and we're hoping to potentially bring it to our center sometime, maybe even later this year. This is kind of just another picture of the setup. And this is not really ready for prime time for all of the disease sites that we treat and all of the kind of amount of disease, because at this point, it's mainly a method for kind of more advanced disease where traditional or standard HIPEC surgery is not possible. But one of the thoughts is that with the aerosolized chemotherapy, maybe there's even a better distribution than with the liquid, just because of the differences between liquid and gas. But that is still an unanswered question. So in conclusion, just very basically to start the day, appendix and colon cancer incidence are increasing, particularly in younger patients, which means more patients will present with disease spread to the abdominal cavity. CRS and HIPEC, or cytoreduction and heated intraperitoneal chemotherapy, offer aggressive local regional therapy for peritoneal spread of disease. These are generally paired with systemic therapy as well, although there's some non-invasive pathologies that you'll hear about later that that may not require that. And PIPAC may be an alternative for later stage disease in the future, but definitely more data are needed. So with that, I'll say thank you, and we'll continue on with the day. I'd like to introduce my partner, Dr. Mogal, who will give the next talk on appendiceal cancer and the indications. Dr. Mogal is an associate professor of surgery at UW and Fred Hutch. He also is the director of the HIPEC program. He did his training at St. Louis University for residency and was similarly in North Carolina, Wake Forest for his surgical oncology fellowship. He's been a great partner for me over the last couple of years since I've been here, and really excited to hear him speak today. Thank you.
Thank you, Jeremy. Hopefully everybody can still hear me. All right. So in putting together this talk for y'all today, I struggled a little bit with whether to cover some basics, because a lot of folks that do come to see us have a basic understanding of what the disease entails. And so sometimes it's hard to know whether to give you more information or less, but I'm going to try to balance the two so that for folks that have never or have very little information about appendix cancer, they derive something, and for folks who have more advanced understanding, they have something to learn also. Let's see. So I have no disclosures. So appendiceal neoplasms, as Dr. Sharib mentioned, these are a heterogeneous group of tumors. We call neoplasm is basically a term for tumor. It doesn't mean it necessarily is cancerous, but that's what the term is. The incidence of appendiceal tumors is relatively rare in the country, less than about 2,000 cases, but these have been rising over the last several decades. Oftentimes, patients can be diagnosed with appendicitis if that is something that patients present with, but many a times patients can present late with what we call peritoneal disease. Prognosis really varies depending on multiple factors, but pathological type is one of the most important. And if it's left untreated in a lot of patients, this disease is unfortunately fatal. And that's why, as a multidisciplinary team, we come into play to try to treat patients with advanced disease with treatments like systemic therapy or CRS HIPEC or other types of treatments that are still being investigated. Symptoms can unfortunately be non-specific. This is a common question that a lot of people ask. Mild indigestion sometimes abdominal discomfort. Patients who have more advanced disease can have fullness and bloating because of fluid buildup. Changes to your appetite or bowel habits can also be, but these are non-specific. Patients can either have some weight gain because of fluid buildup or some weight loss because they have significant what we call cancer cachexia at later stages of disease. Women can sometimes present with infertility. But one of the other common ways these patients with peritoneal disease presents with appendiceal peritoneal disease is when they're incidentally detected during surgery. So patients undergoing surgery for completely different reasons are incidentally found to have peritoneal disease. And I'm sure some of you, unfortunately, have had that happen. In general, appendiceal tumors can be classified as two different types. One is what people refer to as the non-invasive or non-infiltrative tumors. These are the appendiceal mucinous neoplasms that can either be low-grade or high-grade. Typically, they present on CT scans as these enlarged masses of the appendix. I tell people sometimes they can be as big as an eggplant. Sometimes they can be as small as just a little blind ending tube filled with fluid. This is a CT scan that shows a large mucinous tumor of the appendix in the right lower abdomen. When we take a look inside with the laparoscope, these appear, it's hard to visualize here, but you can see this goes all the way down into the pelvic cavity. And when we remove it, sometimes they can be pretty impressive and large. This patient was, for lack of a better term, a little bit lucky that their tumor had not disrupted or had not spread into the abdomen, but even though their tumor was substantially large. But this is how these tumors typically start. And when these tumors have not ruptured, we typically remove them surgically, either laparoscopically or via open approaches or robotic approaches. Our goal is to get a negative margin, but even if the margin is positive, sometimes we go back, but if the margin only has what we call acellular mucin, we can safely watch these patients. We almost always don't do colectomies, or we don't do a bigger operation to take out the colon, except when the pathology shows high-grade tumor. And then when patients come to see us after their appendix has been removed for appendiceal tumors that are either low-grade or high-grade appendiceal mucinous neoplasms, they often ask, what are my chances of developing future peritoneal disease or pseudomyxoma peritonei? And that really depends on whether there's mucin outside the appendix and whether that mucin contains any tumor cells or not. But because there is a risk, as pointed out in the previous presentation, of developing this pseudomyxoma peritonei, even in the absence of rupture, we tend to follow patients, especially high-risk patients, for a long period of time. Usually with CT scans and sometimes with labs called tumor markers, which are proteins that are secreted in the blood by certain tumors. And then there are the infiltrative or the invasive type of appendix tumors that unfortunately a lot of patients also have. These are classified either as mucinous adenocarcinomas, signet ring cell adenocarcinomas. There's a special type called goblet cell adenocarcinoma. And lastly, there's this intestinal type adenocarcinoma, which is also called non-mucinous tumors. And in patients with these types of tumors, we routinely advocate that we remove the colon as a second stage after their initial diagnosis. That's because many a times there is a risk of about 15 to 20% of having lymph nodes that may not be obviously visible on the CT scan. And so we usually remove them through colectomies. Whether we give chemotherapy or not depends on whether the tumors have metastatic disease, the lymph nodes have metastatic disease, and then we similarly watch for any future recurrence using scans and tumor markers. Now, pseudomyxoma peritonei, as a lot of you folks know, some of you who've unfortunately had advanced disease, is when these appendiceal tumors are not just confined to the appendix, but there's usually fluid buildup, usually thick mucinous or gelatinous fluid that builds up in the abdomen. This is a representative picture of what happens in very advanced pseudomyxoma. This is a CT scan showing that this is the liver on the right side. This is the spleen on the left side. You can see all this gray stuff. Basically, it's fluid and tumor surrounding pretty much all the organs in the abdominal cavity because the tumor is no longer confined to the appendix and spread throughout the abdominal cavity. This is another approach of what we see in the operating room. This is a large, bulky omental tumor that's basically formed by mucinous mass and tumor. This is more advanced disease than we typically would like to see. I won't belabor this, but we typically term pseudomyxoma when tumor has gone outside the appendix. Usually the cells reach to a different part of the abdominal lining and attach, and then they form their own blood supply. And this happens throughout the entire abdominal cavity. And if not treated, most patients will unfortunately succumb to their disease because of, say, a bowel obstruction commonly that can happen in advanced tumors. Some patients do ask whether PMP is considered benign or malignant because there has been confusion over the last several decades about what this means. Benign tumors typically tend to be indolent and have a chronic course, which some PMPs do have. Similarly, some low-grade tumors have low incidence of nodal metastases and they don't spread via the bloodstream into other organs. However, by nature, PMP is considered malignant, no matter how low-grade it is. That's because they spread beyond the organ of origin, i.e. the appendix. They can grow relentlessly into the abdominal cavity and invade adjacent organs. And if untreated in a lot of patients, they can lead to fatality. So one of the key components of pseudomyxoma is how we grade these tumors. And so the important thing is to know whether it's what we call low-grade pseudomyxoma or mucinous peritoneal disease, high-grade pseudomyxoma, or it's high-grade pseudomyxoma with signet ring cells. And this has implications in terms of prognosis. And the treatment universally involves cytoreductive surgery and HIPEC or heated intraperitoneal chemotherapy as standard of care, as outlined by Dr. Sharib in the prior slides. But what primarily determines outcomes are several factors. We'll go over 4 of these important factors. Pathologic subtype is the most important. This is a quick slide on what we typically do to plan before surgery. We typically counsel patients about the risk of adverse events with the operation. We want to select patients that have a good performance status or are healthy and are actually functional. Usually we try to get updated scans. We usually have everyone evaluated by a multi-D team. Folks often ask us why, and that's because these are difficult operations to get through. And so we want everybody to be seen by physical therapy, nutrition, sometimes the colostomy nurses, sometimes the social worker if there are social issues. We want to optimize any medical issues or comorbidities. And then we want to safely wait after the last chemotherapy if patients have had chemotherapy to determine when to actually time surgery, because we want to minimize the risk of any adverse events. And sometimes patients get a smaller operation, which is a laparoscopy, where we take a quick look inside of the abdomen to determine the distribution and the extent of disease. The 8th edition of the most recent classification system that we use medically to classify or stage tumors basically classifies all pseudomyxoma peritonei patients as stage 4 disease. As you can see in this bottom right table, irrespective of the grade, irrespective of whether they have cellular or acellular mucin, all patients are classified in stage 4. So what I want you to take away is that, yes, some patients do better than others, but universally, when you have the term or when you are diagnosed with peritoneal disease, it is considered stage 4. As we said, pathologic type really influences overall prognosis. This is what we call a Kaplan-Meier curve. And this tells you how well patients do over time. So the higher you are in the curve and the flatter it is, the better it is for you. And so when patients have only mucin in their peritoneal cavity and no cells, they tend to do the best. When they have what we call signet ring cells, they unfortunately tend to do the worst because they tend to survive much less. And so when we talk about survival in terms of 3 and 5 year survivals, folks with unfortunately signet ring cell tumors tend to do the worst, whereas the acellular mucin patients tend to do the best. And this is borne out in another study that I was lucky enough to work with one of our students on to see. And when you look at the well or moderate and poorly differentiated tumors, you see this. And when you look at patients that have even low-grade tumors, when they have acellular mucin, again, they tend to do better than when they have cellular mucin. Not so much in terms of how long they live, but in terms of how quickly they recur in their peritoneal cavity. This makes a huge difference. The second factor was the PCI score and CC score. I won't belabor this. This was already talked about, but the aim of the surgery is to quantify the disease burden and to leave very little visible disease, ideally no visible disease behind. And that amount of tumor we leave behind is called the CC score. So you want to ideally have a CC score of 0 or at the most 1. In low-grade patients, even if we have a CC score that's a little bit higher than 1, we still can benefit patients with a little bit of an operation just to debulk or remove their tumors. But in high-grade patients, we really want to get all their tumors out. This is a study that was done in a multi-institutional setting that showed that patients with CC0 or no visible disease whatsoever did the best, even better than those with what we call CC1, where we leave a small amount of disease behind. And so the goal is to really get all the tumors out in order to maximize survival. Sometimes we give chemo before surgery. Dr. Cohen's going to talk a lot about this. We sometimes use this as a selection methodology. So patients that tend to have stable disease tend to do better with time. So this is a study that shows that even with high tumor burden, when patients tend to be stable or have responsive disease over time, it really affects their survival in terms of how well they do after HIPEC. And the last factor that determines how well patients do is whether what their biology is. This is a very nebulous term, unfortunately, but it's largely determined. I tell patients all the time, it's the patient's individual tumor genetic profile or their individual tumor genetic signature. And this is determined by multiple factors, but commonly, this is what drives biology. This slide only shows that there are unfortunately some patients, even with what we call low-grade disease, that tend to have much worse prognosis than other patients who have a low-grade disease, and this because they have higher risk features in terms of their tumor biology. Common mutations that we see, which are not unsimilar, but not exactly the same as colorectal cancer, are KRAS, GNAS, and P53. We almost always never see these MSI tumors in patients with appendiceal cancer. And so for those that ask whether immunotherapy is an option, this is one of the reasons why we don't have immunotherapy as a really good option for appendix cancer. This is a systematic review that I did with one of our students a while back that looked at all studies that are looking at genetic mutations in patients with tumors that have appendiceal cancer and that has disseminated into the peritoneal cavity. And what we saw was that KRAS and GNAS mutations go up in low-grade tumors, and TP53 tumors go down, and TP53 tumor mutations are much higher in high-grade appendix cancers than low-grade. And this is one of the more recent studies that has been done. You know, we've struggled with using these individual mutations to prognosticate, and that's because there's so much heterogeneity in how mutations can, present themselves. But when you group mutational profiles together, we see that you can actually prognosticate patients quite well. So patients who have RAS dominant mutations with no other mutations tend to do better, even than patients that have no mutations whatsoever. And while this data can be used in clinical practice, it's pointing a little bit more and more towards how the genetics of the tumor actually affect survival. As Dr. Sharib mentioned prior, our scans are notoriously insensitive to detect very, very small volume disease. And so we need better ways to detect tumors, not only in patients that have not had surgery, but most often in patients that have had surgery who we're just surveilling. And so Dr. Cohen will talk a little bit more about circulating tumor DNA, which is small fragments of DNA that go into the bloodstream. This is being developed to detect cancer early, sometimes for personal therapy, and sometimes to monitor response to treatment. Unfortunately, in peritoneal disease patients, the sensitivity of this test tends to be very low because of the mucinous nature of these tumors. But in patients that do have positive ctDNA, we can use them quite reliably for long-term surveillance. This is another slide showing how when you have non-peritoneal disease, your likelihood of having a positive ctDNA in the presence of disease goes up, but not with peritoneal disease only. This is one of the limitations of ctDNA. This is another slide showing the same thing. These are patients who clearly recurred radiographically, but their ctDNAs were still negative after surgery. And then lastly, one of the things that we talk about when we talk about appendix cancer is the approach to personalized therapy. So how can we personalize therapy? Dr. Sharib, we've been fortunate enough to recruit Dr. Sharib, who's really trying hard to look at some of this data within our own subset of patients, how we can grow tumors within the lab, including the cells within its microenvironment, and how we can use that to deliver individualized therapy for patients. And so this is a study that came out of Wake Forest. Some of you are probably aware of this, that shows that you can actually test chemosensitivity in the lab on these organoid specimens, and then not only tailor their systemic treatment, but also their HIPEC treatment. And so in summary, we have made advances with appendix cancer. The optimal treatment really depends on several factors. Whether we give chemotherapy to patients with high-grade disease routinely is a matter of debate still. I didn't put up those individual slides, but this is an area where we can definitely do trials with multiple institutions to get a better answer. And then early detection using ctDNA is promising, but we need more data. And lastly, personalized therapy is something we're excited about. I think it's the way forward, and I'm hoping that our program will be able to, move in the direction of this personalized treatment in the years to come. Thank you. And with that, I am going to introduce our next speaker. And they actually need not a whole lot of introduction. Some of you already know Dr. Cohen really well. Dr. Cohen is an associate professor, a professor of medicine and medical oncology at the Fred Hutch Cancer Center. She co-leads the HIPEC multidisciplinary clinic at Fred Hutch with me, has been an integral partner and steward of our program right from its onset about 3.5 years ago. We're very excited for her to talk to you today about the role of chemotherapy in appendix and colon cancer.
Hi, everybody. Thank you so much for this opportunity. I really appreciate getting to focus on this. And, I know there've been a lot of questions in the chat already, so please keep those coming and we'll try to answer them. One thing I've noticed is a lot of them have really specific questions, and I would love to answer all of medical oncology in 20 minutes, but I can't. So I'm going to give kind of a broad overview, and then feel free to send in some of your questions. And as much as we can, we'll try to answer them today. So We're going to talk a little bit here about, systemic therapy. And so just thinking about this, we've really focused on local therapy. So a treatment delivered to one body area or body part, as opposed to systemic therapy, which is where I really spend most of my time, a treatment often intravenous, sometimes pills, given with the intention of going through the whole body. And so as we think about the different comparisons, local therapy is more targeted versus system-wide. It's usually used for limited spread, possibly with curative intent, sometimes just with trying to control symptoms, whereas systemic therapy is really designed to shrink the amount of cancer that we may see preoperatively, control the growth of cancer, or the other major time, reduce the risk of recurrence after surgery. So the side effects will really depend on where that therapy is given, whether it's more globally or more regionally. And really only with systemic therapy are we aiming to treat the radiographic visible disease as well as micrometastatic disease or disease that we can't even see. So if you are not well versed in this area, you'll probably know or start to learn that there are a lot of different acronyms and sort of smooshes of names that we'll use to describe the different chemotherapy regimens. So I want to walk through some of that. Our backbone drug is called 5-fluorouracil or 5-FU, and the oral prodrug version is capecitabine, also called Xeloda. And we combine that with oxaliplatin to make FOLFOX, or we combine it with irinotecan to make FOLFIRI. Or we can do what we call the triplet. We'll do all three, and we'll call that FOLFOXIRI or FOLFIRINOX. Sometimes we'll have to omit the 5-FU. We'll call that IROX. And then we can add targeted therapy like bevacizumab, which is Avastin, or EGFR inhibitors like panitumumab and cetuximab. And these are our 5 major drugs of GI cancers. After that, I'm sorry, we know not to mix those 2 targeted therapies. After that, we do have sort of a second tier of drugs. These are mostly oral therapies, and their efficacy is less. So we have regorafenib, trifluridine tapiracil, also called Lonsurf with bevacizumab, and the newest drug, fruquintinib. So what have we seen over time? We're so lucky that surgery has come a long way, but chemotherapy has as well. And what we've seen is that as more drugs have been approved with colorectal cancer, we've been able to see an improved median overall survival. So this is the 50-50 mark of about 30 months, which is tremendously better than we used to see before we had these drugs available. But we know that cancer that's restricted to the peritoneum has a worse prognosis. And so as we look at these curves, and just to reiterate some of what's already been said, when we look at these curves, for those of you who are not used to looking at these, we start with 100% of people alive. And then if you follow it out to the right, you're saying that as the mark drops down, it means someone has passed away from any cause, because this is overall survival. So the people whose lines are at the bottom with the worst survival, that's patients with peritoneal and organ metastasis. Then we have in the purple line, patients with peritoneal only disease, as compared to the best survival, which is non-peritoneal disease in just one organ. So overall, when we look at thousands of patients, we see that patients whose cancer has spread to the peritoneum don't do quite as well. So we need to think about what we can do to help treat these patients. And when we're using chemotherapy, we could give it indefinitely, because there's never a time that you have to do surgery for more advanced disease. It's always this option. And of course, we want to get really good outcomes. We want to give aggressive management for patients, and we want people to do really well. But the reality is we know this is a hard surgery. And so it is totally fine to give indefinite systemic therapy to control the cancer. But if someone wants to try at this surgery, we want to try to give an aggressive therapy as well in the beginning and try to control that cancer. We want to decrease the amount that we can see on scans. We want to shrink and control them, even the ones that are too small to see on imaging. And we know that even CTs or PET scans or any of our best scans don't show all the cancer that's there. And we also want to address maybe microscopic disease so that new sites do not appear after surgery. So if you take your average metastatic colorectal cancer patient or appendix cancer patient, you're going to give a series of different therapies. So we talked about how 5-FU is the backbone drug. So whether it's FOLFOX, FOLFIRI, FOLFIRINOX, you're going to kind of run through those options. And then once you pass those big 5 drugs, you're then down to clinical trials and that sort of second later tier set. And that would be sort of standard management of metastatic disease. But if you have a patient who you think is a good candidate, or is asking for this kind of more aggressive approach, what we would do is plan for chemotherapy given before surgery. We call that neoadjuvant or before surgery chemotherapy for 4 to 6 months. We would be doing scans every 2 to 3 months to make sure that there's no worsening of disease. So we might not know that things are better because it can be hard to see on scans, but we want to make sure that it doesn't get worse. And then around 5 months, as we're gearing up to saying someone's nearing the end of their time on chemotherapy, that's when I'm referring back to Dr. Mogal, Dr. Sharib, saying, okay, I think this person is ready. Let's do the diagnostic laparoscopy now and make that final determination of, did that PCI score that Dr. Sharib talked about, did that go low enough that we think that someone is a good candidate for surgery? And they're assessing and saying, how bad would the surgery be, or how easy would the surgery be? And so that's the decision that what's making at that point. Assuming someone gets to go ahead, we then take a brief pause of about a month, and then they get the big surgery, the cytoreductive surgery and HIPEC. But you can imagine that if you are working at a center that's not well versed in these decision-making, it can be hard to determine if someone is a candidate for surgery. And so what we like to do at our center is, if I'm giving your chemotherapy, great, I'll be assessing you along the way. But if I'm not giving your chemotherapy, then me or my team members or whomever who is seeing you at Fred Hutch would be assessing you at each scan time point and making that decision of whether we continue on with chemotherapy. Do we think we're getting enough benefit that it's worth it? Are we moving towards surgery, or are we not? And so those are good decisions that we want to make with a well-versed multidisciplinary team. So of course, in medicine, we try not to do anything just because we think it's a good idea, but try to prove it as much as possible. And we don't have that many studies looking at cytoreductive surgery and HIPEC with chemotherapy, because you can imagine, if you were in the shoes of the people in this trial, it's a pretty big deal to be willing to be randomized to chemo or no chemo, because most people and most providers have some idea about what they think is the correct strategy. But in this very limited study, the Cairo 6 study, they did indeed randomize patients. Half of them went on before surgery chemotherapy, so neoadjuvant chemotherapy, and half of them went straight to surgery. And the numbers that I put on the side here, so the amount of decrease that was seen, that's overall response rate, how much did actually we see shrinkage? Only about 28%. And I know there was a question in the chat before about how much shrinkage do we expect to see? We don't always see patients' disease shrink, but sometimes we just want it to be stable. And I will also note that these are only 2 drug regimens, whereas if we do FOLFIRINOX, we expect a slightly higher efficacy. So let's say approximately that maybe 1/3 of patients' cancers actually shrink down, 1/3 may be stable, and 1/3 maybe we're not getting the response that we want. But moving on. So in this trial, not everyone even actually made it to surgery of the ones that went on chemo. Some people were deemed not a good candidate for surgery, so not everyone did. But of the ones that did, 89% on the chemo arm had a good surgery with a complete cytoreductive surgery that went on to HIPEC, and 86% in the ones that went straight to surgery. So it was a little bit lower. And then about 1/3 of patients got their chemotherapy after. So importantly, we saw that the complications from the surgery were similar in the 2 groups. So getting chemotherapy did not make things worse. And maybe this supports the fact that by treating patients' cancer, we'll actually get potentially some better outcomes if we are able to give chemotherapy before. We also learned from this that it's really hard to give people chemotherapy after surgery. They're recovering. So that's sort of why we try to give as much of it beforehand as possible. And as we've expanded, and Dr. Mogal talked a little bit about this, we've learned that there's certain drugs that, or certain genes that are altered in tumors, and now we have certain drugs that target those genes. Now, it's super uncommon. Less than 5% of metastatic colorectal cancer will have one of these targets, but we look for them on every patient. So we're looking for things like BRAF, HER2. I know someone put in the chat that they have a microsatellite high or MSI high tumor. We're thinking about immunotherapy for those. Now KRAS G12C, and then very rare NTRK and ELK. But these are really important because if you don't look, you don't find them. So on every metastatic patient, we're thinking about doing some, widespread genotyping to try and understand what makes the tumor tick. I also want to note that there was a lot of press for a while about a drug, dostarlimab, with a complete response rate in local rectal cancer. This got a lot of press. It also got a lot of patient communication with folks wondering if they are a candidate for this drug. And I want you to know that actually the data in the metastatic literature was first. So we've known about this biomarker for a long, long time. We've been looking for it for screening for immunotherapy. So that should be part of your standard of care already. What about after surgery? So let's say we are in this great situation. We did chemotherapy, we did the surgery, and now we're sitting down again and saying, what's next? So we'll be regularly seeing folks talking about symptoms. Are you having abdominal symptoms or digestive symptoms, especially worried about bloating or pain, changes in bowels? And these may be very nonspecific. You might have one bad day. We're not worried about one bad day. We're worried about low-grade symptoms that just seem to be nagging or getting worse, or really acute symptoms. So always be talking to your providers about what you're feeling, because they can kind of have an ear for what seems to be concerning and what isn't. We'll be doing standard blood tests, including tumor markers, CEA, CA19-9, and CA125. It might not be in your provider's standard practice to order all of these, but we typically do for patients who have peritoneal disease. At some point beginning a colonoscopy or endoscopy, and then scans, typically a CT of the chest and the abdomen and pelvis, very rarely a PET scan or MRI. And even with all of this, recurrences can be hard to detect. And so there's a reason why we would try to follow with patients frequently. So taking a step back, sending you all the way back to high school, there are biology basics that every cell has DNA. It encodes RNA, which is translated into proteins. And similarly, we have single cells that can be altered and genetically modified, which can turn, if done in a wrong way, can turn into a tumor or ball of cells. So as we think about sampling and ways of monitoring cancer, we have our tissue biopsy. That's a way of actually taking a piece of that solid tumor. And then we also have blood-based tests. So we have blood biomarkers like CEA, and then we have the so-called liquid biopsy, which is circulating tumor DNA, or this idea of taking a blood sample and looking for those DNA fragments shed by the cancer. So what is circulating tumor DNA? There are low levels of cell-free DNA in all of us. As our cells break down, they release DNA that stays around for a couple of hours and then just gets broken down. But we have learned a long time ago that we can take blood samples and screen for fetal abnormalities in pregnant women. So things like trisomy 21 for Down syndrome was one of the first uses of this, separating out baby's DNA from mom's DNA. But now we've applied this technology to patients with cancer, separating out tumor DNA from the normal DNA. And that's what circulating tumor DNA is. It's this brief glimpse at what the breakdown of an active cancer is shedding into the bloodstream. And if you have more cancer, you should have higher levels of ctDNA, whereas if you have just a rare or small focus, it may be very difficult to detect. So we have this idea of minimal residual disease or molecular residual disease, also called MRD, which is that if you take a scan and you don't see any sign of cancer, but you take a ctDNA sample and you actually pick up these very rare fragments, that's what MRD is, looking for that very small amount of cancer. And the hope is that ctDNA can pick up recurrences faster than what we typically have been able to do. But to date, most of our analyses have been looking back in time at patients whose samples were already collected, or observational, meaning that we're taking the samples, but we don't really know what to do with these blood tests yet. So it's a growing, a vastly ballooning field, but one where we're still learning about it. So why does this matter? Well, again, looking at these curves, if we start out at 100% of patients alive and cancer-free at surgery, we want to keep patients in that spot as much as possible. But over time, we know that some patients are going to recur. So if you take that middle line of all patients, we want to separate out if someone is ctDNA negative and actually less likely to recur, maybe we don't have chemotherapy after surgery, or maybe we want to give less intense therapy. Whereas if someone is ctDNA positive in the red line and highly likely to recur, maybe want to escalate and give stronger therapy and try to decrease that chance. So this is this idea that we want to try to respond to an individual's current status and try to tailor their therapy accordingly. And we're starting to learn that this really is a very exciting biomarker. So as we think about how the curves separate, patients who are ctDNA negative in this study of over 1,000 patients from Japan, people who were negative had really good survival. You see those blue lines at the top, versus patients who were ctDNA positive had a much higher recurrence risk. So we think that this could be a viable marker as a single time point on the left, or as you see it on the right, as we look over time, people who were negative and stayed negative did the best. That light blue is patients who are positive and turned negative. So maybe that chemo given after surgery was helpful, versus patients who have a positive test and stay positive. That's the red and green lines. They don't do as well. And so we try to use this marker to help us guide therapy. Now, some of that data was from early stage people, but we do have data in stage 4 as well. So this is from a real world analysis. So patients who they were getting ctDNA tests as part of standard care from their provider. We saw a very high detection rate of ctDNA before surgery, but about half of them were positive after surgery. And we do expect about half of stage 4 patients at least to recur. It may decrease during therapy, but many of these patients will still go on to stay persistently positive. So we know that the stage 4 population has a higher recurrence risk. And so ctDNA may be able to help us guide therapy there. On the other hand, we also know that if we can help patients clear the ctDNA, so looking at 1 time point versus 2 time points, if this DNA is negative and stays negative, that seems to do better. Those are the patients in the blue lines. Whereas when someone stays positive, of course, we see a very high recurrence rate there. So we're starting to figure out how to adopt this into practice. So what do we do in clinic? We're thinking about what's the goal of therapy, what types of treatment has someone had, and what types of treatment are they still eligible for? What medical issues does that person have that might impact their treatment decisions? Have they had any genetic testing on their tumor, which we call molecular testing? Do any of those results help us get one of those unique targeted therapies if we're lucky? Could we add drugs to make them a better candidate, or take away drugs because maybe they're getting really sick from the chemotherapy to try to prepare them for surgery? And really, does an attempt at surgery even make sense? These are the things that are kind of running through my mind and what I'm talking about at Tumor Board with Dr. Mogal and Dr. Sharib. Okay, and with that, I'm going to stop because these trial updates are going to come at the end. So thank you very much for listening to this section so far. We're going to be typing away in the chat, so please keep sending your questions. But now I believe we have a 10-minute break. And let's see. Oh, we are a little bit behind schedule. So let's aim maybe more to come back about 10:40. And so feel free to hop off for a minute, use the bathroom, whatever you need to do. And we'll rejoin together at 10:40 with our next speaker. To the second half of our program. Thank you for staying with us for the second half of the program. The feedback form was shared as a link in the chat, and you might have just seen it on the screen, and we'll have it put up at the end, but it's extremely helpful for us to have some understanding of what was helpful to all of you and what you want to hear more of or less of, or any feedback that you have for us. So please continue to fill that out. Even if you have to leave early, it's really much appreciated. So it's now my great pleasure to introduce Tal, who is one of our beloved dietitians at Fred Hutch. And, you know, for all that we know how to do, sometimes the devil is in the details. And so we really rely on supportive care services like Tal in nutrition to help people just feel good in such bad situations. And we know that taking care of patients holistically is the way to help everyone feel better. So I'm very honored to turn this over to Tal, who is going to talk a little bit about how nutrition plays a role in patients who are undergoing HIPEC therapy.
Thank you so much. Like Dr. Cohen said, my name is Ozery. Can I just get some confirmation that you can see the slides here?
Yes.
Wonderful. I am one of the dietitians on Dr. Mogal and Dr. Sharib's surgical team, and my goal today is just to help understand the role of nutrition during HIPEC treatment. And there we go. So first, just preparing for the HIPEC surgery. Like Dr. Mogal mentioned, nutrition is going to be one of those automatic visits that is scheduled along with all of your other pre-surgery visits. And generally, people are coming from a chemotherapy break. So there might be some side effects that we are still dealing with, depending on what type of chemotherapy you've received. But the main thing that we're really focusing on here is just maintaining our weight, specifically our muscle mass, and optimizing kind of our nutritional status. Immunonutrition is a term that we use to refer to these shakes that we are utilizing pre-treatment. There's a lot of evidence that drinking these shakes that contain calories, protein, omega-3s, arginine, can help reduce the risk of surgery complications, infections, hospital stay. And generally, the idea is that you're drinking about 3 shakes per day in addition to your normal meal. Nutrition after HIPEC, like Dr. Mogal mentioned, Dr. Sharib mentioned, the surgery itself can just depend on where the disease burden is. So this is often very variable. I would say for the majority of our patients, most people are following the limited fiber diet for about 3 to 4 weeks after treatment. This will be something that the inpatient dietitian will discuss with you in the hospital. And then after you're discharged from the hospital at Fred Hutch, you are scheduled with an outpatient dietitian like myself about once a week for about 3 to 4 weeks after surgery. And what we're focusing at that point is making sure that your body is getting enough fuel, getting enough nutrition to heal from the surgery. So oftentimes we are dealing with side effects like not feeling very hungry, lack of interest in food, perhaps feeling full really quickly. And then depending on what else is removed during surgery, we can see things like nausea, constipation, diarrhea. So there's a lot that we can do with food to help support the body during this process. But I would say our main focus is really on that you are maintaining your weight, specifically that muscle mass to help with recovery. We see that nutrition starts to improve about a month after surgery, but it can take as long as 3 to 6 months or sometimes a little bit even longer to get back to your baseline of your dietary meal and eating pattern. So like I said, you will be counseled in the hospital about a limited fiber diet. And then once you're meeting with me, you'll be meeting with me for about 4 weeks. We can discuss how to integrate that fiber back into your diet in a systematic way to make sure that we are not exacerbating any of those side effects after surgery. We can discuss the kind of lack of interest in food, feeling full really quickly, and how to be really efficient with our calories and protein. So looking at maximizing our quality of life after that 3 to 6 sort of recovery time period, it's important that you continue to make sure you're getting adequate calories, lots of protein, physical activity to keep that muscle strength. And of course, as always, stay hydrated. And if you need to continue to work with a dietitian or a physical therapist to do so, that can be really helpful. For some people after surgery, again, depending on what's removed, we can see more long-term modifications of our diet. So for someone who is at an obstruction risk, we can see that you might need to follow a limited or a low fiber diet for longer. Short gut syndrome. So if there is a lot of your bowel that is resected during surgery, it can be really difficult to get adequate nutrients absorbed by our GI tract. So learning how to stay hydrated, smaller frequent meals, and perhaps even supplementing with vitamins and minerals if it's necessary. And then if there is an ostomy involved, there's a lot to learn there about what you might tolerate as your kind of new normal diet and dietary meal pattern. And then a lot of my job is also myth busting. So just talking to people and discussing some information that perhaps they've heard from family, friends, or internet. I would say by far the most common one that I hear is sugar feeds cancer. Keep it really simple here. There's no need to restrict our carbohydrates. Eliminating glucose or carbohydrates from our diet is not helpful in these situations. There's no evidence that it'll treat the prognosis of your cancer. it's always a good idea to limit our non-nutritive, or sometimes you'll hear that as like empty calorie carbohydrates like soda, juice, and candy. But outside of that, our healthy carbohydrates, our whole grains and starches are a very important part of our diet. Other fad diets we hear, there's lots of them, but alkaline diet, ketogenic diet, and fasting. For GI cancer specifically, there's no studies, there's no evidence that this is helpful. And then supplements, there's no supplement that has been proven to prevent cancer. So we only really recommend supplements if there's a clinical deficiency or if for some reason you're unable to get that in your diet. And then here are some great resources for you, some evidence-based resources for you regarding nutrition. You can definitely feel free to go back and look at the recording link to get access to these. The two that I'd like to point out is Cook for Your Life, a really nice glossary of recipes that have been developed by dietitians like myself and the researchers at Hutch. And they all align with the American Institute of Cancer Research's evidence for diet and lifestyle, what we call like our survivorship recommendations. And that's another great resource as well if you're looking for evidence-based nutrition, physical therapy, advice for the long term. And then feel free to type in any questions into the chat and I will message you back as I can. But thank you very much. I believe our next speaker is Barb, Regis.
All right. It is my thank you, Tal, for that wonderful presentation. Please, as a reminder, put your questions in the chat. Tal, I believe there are a few questions relating to nutrition. It is my distinct pleasure to introduce Barb Regis. Give me 1 second here. So Barb is a certified physician assistant at the Division of Hematology and Oncology at the University of Washington Medical Center. She's been a PA for an extremely long period of time, but focuses now on survivorship. She provides care in the survivorship clinic at Fred Hutch and sees patients who have completed their treatment and now who have moved into their surveillance phase of their condition, or those who are past surveillance but now are trying to figure out how to live their best lives. She's a very strong patient advocate because she's always trying to make sure that everybody has exactly what they need after their cancer journeys. And we're excited for her to share a little bit about survivorship long-term after HIPEC. Welcome, Barb.
Can you see my screen?
Not yet.
Oh. Okay. For some reason, I'm at home on my iPad, on my laptop, and it's not showing it. It's showing desktop 1. Can you see it now?
No.
No.
Barb, would you like me to share your slide?
Did you mind doing that, Ritu? I really apologize for that.
No worries, sure.
Do you need me to stop sharing?
I'm ready.
Okay. Thank you so much for the opportunity to present today. I'm going to talk a little bit about empowering you life after HIPEC. Next slide, please. Today, we're going to chat about a few things, understanding survivorship, challenges that affect us all, diving into distress reactions, Operation Thrive, and what a survivorship consult visit at the Hutch looks like. Next slide, please. First of all, there's a lot of different thoughts of who a cancer survivorship is. So I wanted to share with you the NCC definition that was just updated in 2023. An individual is considered a cancer survivor from moment of diagnosis through the balance of life. This includes survivors living with cancer and those free of cancer. Next slide. What's exciting to me is just take a look at this graph, how many more survivors there are. And it's because of the great work of the physicians that you've heard from today, and also all the research that's being done around the country at the Hutch. And so, you know, there's so much to look forward to. When you see the numbers from 1975, less than 5 million survivors in the United States to well over 20 million projected in 2040. There's so much hope. Next slide, please. I thought it was important to just share this with you. There was an NCCN survey that was done in 2023 because a lot of people still are confused as to who is a survivor, who's not a survivor, those kinds of things. And when they asked the patient about their survivorship, 90% that completed treatment said, hey, I'm a survivor. 67 still in treatment. But what really stood out to me was 72% stage 4 patients that are living with their cancers are considered survivors. But some of the frustrations that are happening right now is that sometimes they feel like when they go back to their primary care providers, they are not getting their questions answered and they're not sure what to do moving forward. Next slide, please. I just wanted to share this slide with you because I think we can all say that we can relate to something in this slide, as I too am a cancer survivor, melanoma stage 3. Next slide. You know, as we go through our cancer journeys from moment of diagnosis all the way through, so many things hit us, you know, the psychological stress, what our quality is going to be of life, and many challenges throughout the spectrum. We're going to talk a little bit more about that with some surveys that were done with patients. Next slide. So what stuck out to me is that when they, you know, interviewed some survivors in the last survey in 2023, I wonder if a lot of people really, if there are more people that actually are feeling this way, which really didn't say that. For example, you know, a lot of people, you know, when they had their cancer treatments, especially a lot of the chemotherapies that were shared today, you know, there's issues with energy. 59% of patients said, you know, I have less energy, neuropathies, pain, incontinence, sexual function. Next slide, please. And then the big one, all the emotional concerns that go through our cancer journeys. Big one, the elephant in the room, the fear of recurrence. You know, what is my appearance going to be like? How am I going to deal with family members and these relationships? You know, starting to realize that you're going through a lot of grief. And, you know, as we go through our cancer journeys too, you know, post-traumatic stress. Next slide, please. Those who appear to be functioning well may have needs that are not observable. Next slide. I want to dive into distress reactions of survivors. So all of you that are cancer patient survivors on this, I want you to kind of think about your survivorship and how this applies to you a little bit. And so, you know, we get that phone call or we go into our doctor's office and we get that you have cancer, the C word. You know, all of a sudden, it's all the uncertainty. You know, what is my treatment going to look like? What is my future going to be after treatment? Am I going to get through treatment? You know, feeling, you know, insecure. A lot of things that hit us is like, what's going on with like, am I going to be able to work? How do I care for my family? And as we know, these therapies are really expensive. And sometimes, you know, people don't have the best health insurance. So how's this going to impact my family? Am I going to go bankrupt over this? These are all the things that, you know, we think about as cancer survivors as we're getting these great therapies and learning to live our best lives. Next slide, please. Grief and loss. You know, this is a big one. Like, after I have treatment, am I going to be able to do the things I was able to do physically? And for me, for example, I was a long distance runner. And after my therapies for melanoma, you know, I can't do that anymore, but I'm still living a good, great life. What's my body image going to be? Self-esteem. But the big one, I think, is independence. No one that gets cancer wants to lose their independence or their identity. But what happens a lot of times is that we have to reach out to people for help, and we're not used to doing that. Next slide. What will be my new norm? That's the big one. You know, many cancer survivors will share with me in appointments is like, I don't want to be thought of as John, the cancer patient. I want to be thought of as John, the person who is dealing with cancer. You know, will I be able to adapt to these challenges? You know, will I ever feel whole again? You know, a lot of it's about perspective and figuring out, you know, how do you work through all this? Will I finally be able to accept my life as it is? And as I will say, you know, can I be living and not existing? Next slide. the big one, and this hits all of us, even when I go for my surveillance appointments, it's like going down that rabbit hole of the fear of recurrence, and as a result, you're not sleeping well, finding less pleasure in life because every time you go into the doctor's appointment, you're like, what if? And the thing is that we need to work on how we can deal with that and still work with getting the best quality of life ever. And so, our guards are always up. Next slide, please. In the words of a melanoma survivor, every day I would ask myself, why me? Then one day I realized, why not me? At that moment, I knew that I had to figure out how to live my best life knowing it would never be the same. And that happens to be me. Next slide. Next slide. So what can we and what can we not control? Yeah, we can't control our age. We can't control our gender assigned at birth or genetics, but we can control the social, our lifestyle, and our general health. Next slide. So let's dive into a little bit of lifestyle. Nutrition is vital, as we just heard about, nutrition from our great RD over there, taking advantage of being able to consult people and making sure that we're eating correctly and we're listening to the advice of the professionals. Exercise, you're not necessarily going to be able to do what you did before, but starting out slow, get out there, walk every day, breathe the air, just start moving. Alcohol, get rid of it. Substances, get rid of it. Quit smoking, and then work on your sleep. If you're not sleeping well, let's figure out why, because sleep's critical for emotional well-being, immune function, and coping. Next slide, please. Do not isolate. This is the big one. Let those that care help. Prioritize self-care. It's so important. We talk about that in these visits, and so many people are worried about everything else, and they're not taking care of themselves. So I give the recommendation every day, do something for yourself, even if it's only for 15 minutes. Turn on the music that you like, take that walk, go do a hobby that you like to do in the past, get involved with that again. Manage your stress. As I said to myself, pets can be amazing. And this is my dog, Jules, and she's actually on the floor right beside me right now. And she's enjoying a little boat ride on the South Lake Union. But just a pet, whether it be a snake, a rabbit, a mouse, a dog, a cat, whatever, that unconditional love can really help us through those journeys. Next slide, please. General health. I can't emphasize enough that, we get our cancer diagnoses. You're listening to everything that your care team says. But sometimes what happens is that routine follow-ups with our primary care providers are put off to the side. And sometimes primary care providers aren't even sure what to do with patients with new diagnoses of cancers. But it's really important to get those physical exams. It's important to make sure you're doing your preventative screening for other cancers, because if you're being treated for an appendiceal cancer or a colon cancer, the last thing we want to do is see that, a breast cancer is developed. So get that mammogram, DEXA scan. Make sure you're getting prostate cancer screening, skin cancer screening, vaccines. Next slide. I wanted to talk briefly about our cancer survivorship program. The mission of the program is to improve the lives of survivors through integrated research, education, advances in clinical care. Next slide. At our clinic, we see patients at all phases of their journey because we feel, and I feel very much, that it's up to the patient when they're ready to be seen. So, any patient is welcome, whether they've been treated at the Hutch or not treated at the Hutch, as long as they live in the state of Washington, and they can be seen in the clinic, at the Wellness Center, or via telehealth. What's really neat is that we dive into your individual records. And what we do is, based on that, come up with your summary of your treatments thus far and a care plan moving forward. So, for example, if you had certain type of radiation, you may be at higher risk for hearing problems. You may be at higher risk for cardiac problems. We want to make sure that you know exactly and you're empowered moving forward as you go through your journey. The great thing is that most insurances consider this part of your cancer journey, and it's covered. Next slide. This is what patients are saying. Patients are surprised to learn the program exists. Also, patients are saying that, they're really concerned that their PCPs do not know how to address their needs. They feel more empowered after receiving the treatment summary and care plan. And PCPs share that with me too. When I send them a care plan that says, hey, they're going to see their oncologist here, they're going to see your surgeon here, they're 60 years old. And for some patients, like let's say they had radiation, in that regard, I'll say, hey, they need a skin exam yearly. They need a DEXA scan. And so depending on what type of therapy, it's very individualized. And the patients can go with that plan to their PCPs and say, hey, this is what I need to get done. And then the PCPs in regard say, you just made my life easier. So patients see the survivorship provider as a valuable member of their overall healthcare team. Next slide. I want to give you a prescription today. It's called the Gratitude RX. Take a dose every morning, may cause shift in perspective, may cause feeling of abundance, decrease feelings of fear and anxiety. Next slide. We have a survivorship program on June 1st. You're all invited to it. There's a little bit of information about the program and a way to register for it. And it includes a lot of different people with different cancer diagnoses in their journey. And we would hope that, you might want to attend that. Next slide. Next slide. Thank you so much for your time. And I really appreciate the opportunity. Thank you.
Okay, well, really, really lovely talks so far. And again, keep sending all these great questions in the chat. We also want to bring it home now and talk about, we're on one side of things here and what we are doing best to try to help patients, but we also want to hear it from somebody. And it's so my biggest honor to invite Steve to speak next. He is one of our patients who has been through this process, continues to be in this process. And I think it's great just to hear what it's like from the patient perspective. So Steve, it is my pleasure to turn it over to you to just talk a little bit about what it's been like.
Thank you. Do you want me just to kind of start from where okay, well,
yeah, you can start from wherever the story kind of feels right to you. We obviously didn't expect you to have slides and things to share. This is just a spot for us to kind of pause and listen.
Okay, well, it started, I've worked outside my whole entire career, so I was used to kind of being bunged up a little bit, and I ended up hurting my back, and rather than go to my primary doctor, I tried massages and chiropractic didn't work. So I finally went to my doctor, and he sent me in for an x-ray and found out that I had a tumor on my appendix, and he immediately referred me to you guys down there at Fred Hutch, and so basically I met with Dr. Mogal, and he was gonna, he decided that I was a good candidate for the HIPEC, he thought, and so then we scheduled the HIPEC surgery and went in and did kind of an exploratory, and it was decided that I should take chemo first, and so we just stopped that, and then I went to Dr. Cohen, and she got me squared away on chemo for probably 6 or 7 months, 8 months, right? 15, I think it was 15 courses then. And so we live in Fighty Harbor, so we had to come down to Seattle. Usually it was on Monday. You guys did really good by making my schedule work out with the ferry and everything. And we'd come down on Monday, and we'd stay and get my chemo infusion, and then put a pump on me, and we stayed Tuesday and took it off Wednesday. So that went on for 15 times. And then it was determined that I was good to try the surgery again. And so I was off the chemo for a while, and Dr. Mogal took over and went in and did the surgery and proceeded with it. It was in September, the end of September last year, and it was a 14-hour surgery. I felt really bad for the surgeons because they were exhausted. I just slept it all day. They were really hard. I appreciate that. And then I was told from Dr. Cohen and Dr. Mogal was true. I didn't know it was going to all pan out the way they said it was, because sometimes it didn't seem like it was going to. It was Dr. Mogal told me to be between 4 and 6 months of recovery, which was the longest recovery thing that I've ever had to deal with, and it was pretty spot on. It was pretty tough 4 months, and then once the 4 months started coming in, I started progressing real noticeably. It was real nice to start feeling better. I didn't for the dietitian part. I wasn't eating very good, so I had to come home with TPN, and we did that for probably 2 months, right? And my wife did all that for me. She stuck me every morning and took it out every night, and finally got rid of that. That went real well. And started, I can remember the first time, we have dogs too, which is really cool because I'm pretty obligated to them. And the first time I took him for a walk, our state park, our backyard is a state park. And I remember it was like a 600-foot walk. And now our favorite walk is a 2.2-mile walk every day. So we plug along pretty good. And I just feel better every day. And we kind of decided not too long ago, we had a boat and we sold it. And we didn't think living out in the San Juan Islands without a boat was the smartest thing to do. So we just recently bought another boat. So we're going to start crabbing and shrimping here pretty soon. We figured we might as well make it pay. So we're having a pretty fun time. It's kind of getting back to life is normal again. And my wife too, I couldn't have done it without her. Couldn't have done it without my doctors. Dr. Mogal, you said something to me that stuck in my mind before my surgery. You said, be the best you can be. And I stuck kind of to that. And it was good. Lost a lot of weight. So I froze pretty good during the wintertime. Didn't have much muscle on me. That's what the hair is. My wife keeps trying to cut my hair and I keep telling her it's too cold. But yeah, that's kind of my story in a nutshell. I'm so happy that everything went like it did, and made some friends with my team down there with the nurses. There's some good people there. Every one of them was good. We always had a good time. Just got good people. You're good people. If there's anything else, then you're probably going to have to ask me because I'm not pretty prepared to. I can answer all kinds of questions, but what happened in a nutshell. And basically, right now I'm on cancer drug, and I do that for 2 weeks on and 1 week off, and that's going good. I don't have any side effects anymore from it. It did have some with that medicine. It made my hands and my feet kind of peel a little bit and hurt. But once I figured out what to do, when she told me just the self-care took all that away. It's all tolerable, all doable.
Well, this is amazing, Steve. Thank you so much. I think there's a couple kind of individual one of them is asking if you had peritoneal spread prior to your HIPEC surgery. Yes, I think the answer is yes. That's why we gave you the chemotherapy before, but
yeah, there was information over the last year and a half.
Oh yeah, it's a big blur, right? But I think you also provided some inspiration for folks that might be a little bit closer to the surgery and thinking about how it might feel like forever, and knowing that you were in that position and felt that way and are doing so much better and are now thriving now. I'm sure it is very inspirational for other people to see and know that it could get better.
Yeah, it was pretty tough. It was a tough surgery, but wasn't that tough looking back on it, to forget all the bad stuff. Now it's just all about the good.
All right. Thank you for sharing that story, Steve. I think there's lots of people on the attendee list that are commenting about how brave you are to share it, and that how your story is inspiring to a lot of them. So we appreciate you coming out here to talk to us about it. With that, I will introduce our next speaker, who is Jim Carroll. So Jim has been a board member of the ACPMP, which is the Appendix Cancer Pseudomyxoma Peritoneae Foundation. He'll talk a little bit more about that, so I won't go into that. But he joined the Research Foundation board in 2009 and is currently the president of that board. And we are very lucky and glad to have him here today, partnering with us on this event to talk to you a little bit about the work ACPMP does and how they partner with various institutions to provide funding to critical, research projects in the realm of appendix cancer. Thank you, Jim, and welcome.
Thank you, Doctor. Appreciate it. And to the Fred Hutch team, also appreciate it. Trying to move my slide. It doesn't seem to be working. Bear with me. Try this. There we go. Again, thanks to the Fred Hutch team. It's an honor to share our story today. I can tell you that in 2008, the foundation was formed by a wonderful woman by the name of Lisa Luciano and another gentleman by the name of Mike Dvorsky, and a core group of people that were affected by appendix cancer, and they recognized the need at the time that there wasn't really any dedicated funding going towards research and education. So our mission began to fund and support research to discover new treatments for appendix cancer with the hope of one day finding a cure. And secondly, to fund and support educational programs for healthcare professionals, patients, caregivers, and families to keep pace with the evolving science and to increase awareness about this rare cancer. And our mission has stayed fundamentally the same since the foundation was formed. All of this work is made possible by the generosity of our donors, and that is people that are donating funds to us, and also by people that are creating events and doing peer-to-peer events and donating those funds to us. This is our core team, and it's a small team. I joined in 2009, Judy Culbertson and I, when we were affected, when my friend Dutch lost his life and lost his battle, and the rest of our team have all been affected. Deb Shelton joined about 6 years ago. Alyssa and Jamila, our staff members, are here just in the last year, but a small but powerful team, hopefully. We have the benefit of an outstanding medical advisory board led by Dr. Laura Lambert, and this board basically provides us tremendous advice to how we're operating our foundation. They are a resource for anything medically related, if we need to put together some documents, etc., and we are appreciative of all of them. We also, in the last year and a half, created a scientific advisory board, and the difference is that the scientific advisory board, led by Dr. Halawate, was really put together when we brought our grant program in-house. So they are the individuals that interpret and evaluate all the submissions for us and provide recommendations and ratings in order for us to administer our grants and give out the money for research. The core of our grant making has always been our Catalyst grants, which consists of there are $50,000 grants over 2 years, and it's meant to provide seed money for basic scientific research. And this year we are actually creating what's called a Changemaker grant, and we're looking to significantly increase the amount for a grant that hopefully will be put together and issued by the end of this year. This year, or since inception, we've been able to issue $1,800,000 for research, all directed at appendix cancer, and that was 51 research grants over the years. This year, our beginning grants, and we're going to have another cycle of Catalyst grants before year end. And as I said, we're hoping to also have a new grant that we offer and award. But we just announced 2 grants going out to Dr. Shen and Dr. Wagner. So they were our first cycle award winners. We also, earlier in the year, funded the SOS Young Investigator Grant for $25,000, and Dr. Michael White was the recipient of that. And we also funded $18,000 travel award grants, and those grants were for younger doctors that were submitting papers for the SSO symposium. So money well spent, we believe. We support a variety of empowerment initiatives. These are all on our website. Not enough time to go through them all today, but ranging from a new patient guide to published research repository. So there's some tremendous information on our website for patients to access. From a standpoint of upcoming initiatives, from our fundraising program, our main annual fundraiser consists of our Global Awareness Walk, which is really, it started in Philadelphia as a in-person walk, and over the years it developed to be a remote walk with a lot of flexibility where Anyone can register, contribute, can do a personal walk with your friends and family, or do something more significant. We have a walk in Chicago that's now has significant amount of attendees, and that's our primary fundraiser annually. We are also planning for August Appendix Cancer Month, and that will be a hybrid of fundraising events and educational events. Included in that, we have a Light Up Amber campaign where we light up buildings, and a whole variety of other things. Educational webinars. Last year we did weekly webinars. We're planning it again. And then following that, typically we have our annual multi-regional symposium, which is a one-day event, typically in October or November. We provide helpful resources. All of this can be found on our website. We've got a long-term video library of presentations, as well as fact sheets for new patients, brochures, information on our research grant program. So how we support the programs and initiatives, just, you know, the fundraising, as I said, is a combination of things that we initiated, like the walk. And then there's a whole host of people that stepped forward and said, hey, how can I contribute? How can I do something? And that has been everything from social media fundraisers that are very easy to do, to larger golf tournaments, cornhole tournaments, things along those lines. And typically we work with people. If they come forward, we help them organize it and provide the platform in order for them to register people, things along those lines. We do this with the benefit of a variety of volunteers. As you can see, some of the people who have been long-term volunteers for us, contributing in a variety of ways. We have education committee, we have a fundraising committee, and I think the research committee is in planning, but we always welcome volunteers and are appreciative of the people that have made us successful. This is just a scan for, you know, you can sign up for a variety of social media registration so that you can always stay in touch with anything that's going on or any of the information that we're putting out. And I think I lost the last slide, but the last slide was really just a registration QR code to our June event. And with that, I just want to thank the Fred Hutch team. Steve, stay strong. It's a wonderful story. Appreciate it. And thank you very much. Appreciate it.
Thank you, Jim. We appreciate you speaking today. Up next, I have the pleasure to introduce Adele Jasion, who's coming to us from PIPAC PAL. She's the president of the organization and has been a partner with us for this event for the last few years. We'll just try to keep to 5 minutes for this presentation, just so we can keep running on time, but take it away, Adele. Thank you.
All right, I can do it. Thank you, everyone, for being here. It's my pleasure to represent PIPAC PALS. And Barb, everything you said is what we talk about day in and day out. So really, really, really enjoyed the survivorship comments and the importance of living your best life and following everyone on their journey at whatever point that may be. PIPAC PALS is the world's oldest global volunteer-run organization that gives hopes to patients and caregivers with appendix cancer and related conditions like PMP. It was started in 1998 by our founder, Gabriella Graham. You've heard me talk about her before, and you know, we benefited greatly from Gabriella's efforts, and we're continuing to help patients every day. You know, all of the medical discussions, the physical journey is very, very difficult, but as Barb so eloquently mentioned, the emotional journey is just as difficult, and we are here to provide support to patients throughout their journey. Next slide, Ritu. Okay, our leadership team, as I mentioned, we're volunteer run, led by patients, caregivers, and professionals. And we're committed to providing support and hope to people affected by this. We do a lot. We're in contact with patients every day. We have a variety of programs that I will discuss in a minute. We coordinate programming. Our Hope Zoom programs, one of our most popular programs, we're just here. And here's our board, and many of you on the call, I think, have interacted with one or more of us. Myself, Charmaine, Mike, Dave, Mark, and a host of volunteers that we just couldn't do our work without them. And if you're listening, Connie, Jamie, Lindsay, Misty, Linda, and many more. We appreciate your efforts. We also have a medical advisory board, relatively new from a formal perspective, although we've had the privilege of many of the specialists being supportive of us for a long time. Dr. Mogal, one of our very long-time friends, and has also graciously agreed to be on our medical board. Next slide. Okay, some of our programs, Hope Zoom, many of you are familiar with that. These are twice weekly Zoom calls. We meet Wednesdays at 6 p.m. Eastern and Saturdays at 11 a.m. Eastern. These are just sessions where we go around the room, listen to what's going on with patients and caregivers that join us, and we learn so much from each other. We're sharing stories, we're supporting each other, we're sharing information, and we're with our fellow patients and caregivers as they're living life. Resilient resources. We have a variety of materials on our site, and also as part of Hope Zoom, we have specialist presentations. We'll have a link to this session on our site, and we just appreciate being part of the continuum of providing information that's important to our patients. Next slide. Bare Bottom Bears is one of our longtime legacy programs. We send bears to patients, and there's an example of one there in their hospital gown. And it's just something to show the patients that we're thinking of them, we're there with them. Get Well and More cards. There is nothing more uplifting, supportive, hopeful than getting cards from patients around the world. And we'll put people on our card list for anything. Oftentimes it's going through surgery, but anytime somebody needs a note of support and encouragement from a fellow patient or caregiver, we're here to send them. And we have just an amazing list of card writers that volunteer to send these cards. Next slide. We're on social media, so please connect with us on Facebook, Instagram, and LinkedIn. Mentors, we do provide one-on-one support. We do provide a lot of support through our Hope Zoom, our twice weekly calls, but we do provide one-on-one mentoring. So you can connect with us through any of our challenge so that we can have more of a one-on-one session with you. Broad Blankets, a relatively new program, but one of our patients, her father wanted to give her some comfort as she was recovering, and so now they are helping us send blankets to any patient that needs them. Pals Living Life, we're here to support our pals, cheer them on, be with them through better times and more challenging times, and we're just with them every step of the way. Next slide. Where you can reach us anytime, info@pmppals.net. or visit our website, pmppals.net. You can sign up for our monthly e-news and event alerts. And then one thing that we do annually, even though technology has allowed us to connect 24/7, any day, anytime, sometimes there's nothing like meeting in person. So next slide. So we have an annual meetup, and so these are some pictures of a previous meetup. And as I mentioned, just the fellowship and seeing each other in person, I have no words. I just have no words. There's just nothing like giving a hug to somebody that remotely we've been with them through various stages of their journey. And next slide, we have scheduled our 2024 meetup, which will be in Scottsdale this year. So mark your calendars. Everybody on this call is invited. And everybody not on this call is invited. October 18th through 20th. So please join us. Next slide. Support. As I mentioned, we're totally volunteer run. So we appreciate, and any support you can provide. There's a link to our site if you want to make a donation. Also volunteers. If you're a patient that is a point in your journey where you'd like to give back to other patients, please connect with us. That there's nothing more heartwarming than interacting with our fellow patients. And then my last slide, again, we have hope for you. Hope is our theme, and we're here every step of the way. And as I mentioned, please connect with us through one of these channels. Please join us on a Hope Zoom call. And with that, we appreciate being here and telling everyone a little bit more about PALS.
Thank you. Incredible patient advocacy, patient support, and just really good human connection. And we so appreciate everything that you do. I'm going to now close this out, and we're going to talk a little bit about the future as we see it in terms of clinical trials, opportunities, and just some thoughts for where everything is moving. And so with that, let's see, make sure these work. So I'd like to, encourage and empower everyone as you're thinking about treatments to look into clinical trials, whether you're seen at our site or another site. There are, hundreds, thousands of trials, and every trial is listed on this website, clinicaltrials.gov. So it has to be registered. It has a unique identifier, and, you are welcome, whether you're a provider or a patient, to search for different trials that may be relevant. You can put in your disease name, you could put in a gene mutation, and start to kind of look around, because I guarantee you there is not one provider that knows every trial going on. And there may be certain areas or centers that you're interested in going. Maybe you have a sibling in another city, and so you would consider a trial in that area. So it's good to kind of look around if that's something that you want to do. Just to teach a little bit about clinical trials, we have different stages. We have phase 1, where they're really just trying to figure out, is the drug even safe? Maybe it's a new drug, maybe it's a new combination, and they're trying out different doses to figure out if it's safe. After that, we're going to be looking at phase 2, see if there's signs of drug efficacy, and then phase 3 to see if it's better than standard treatment. And I apologize, you probably hear my son banging on the door where I am, so excuse me as I move a little bit here. This can include different types of drugs, first in human studies, randomized studies, and it really depends on where you're at in the trial process about where that would be. Not all of them have a placebo, and not all of them would you get the study drug. So just as a snapshot right now, we don't have any trials right now for sort of unselected colorectal cancer. Because the one that we have is imminently closing, but we may have more coming soon. But we do have trials for a few unique subgroups, whether it's a BRAF mutation, specific KRAS mutation. So it's good to know the specifics of your cancer, as well as HER2 directed therapy. So these are trials that are opportunities, of course, only for a unique group of patients. But if you're in those groups, we want to help you get on those treatments. And we have lots of phase 1 trials. The problem is they're constantly opening and closing, and sometimes people may wait on a waiting list for a long time. So check back often. And if you're interested in phase 1 studies, you would need to get a consultation for us to be able to really assess what's a good option for you. We have some new things coming with ASCO last year, which is our big annual medical oncology meeting. They started talking about some intraperitoneal treatment with radium. So nuclear medicine trial. So there's some new things that are coming down the pike that we hope will provide options for patients. Of course, they need bigger studies, but there are new therapies to come. Dr. Sharib already talked a little bit about PIPAC, and we have trials that, you know, we don't have open at our site, but we can help you think about if you might be a good candidate for, and maybe eventually we'll be able to offer this at Fred Hutch. And then we're trying to move the field forward as much as we can. We're taking tissue samples on certain patients' blood samples. Dr. Sharib and I both have grants to look at this in looking at different types of tumor profiling. And so, again, we hope to try to remain at the forefront and really appreciate the partnership with all the patients that we treat to see if we can help continue to do that. We're looking also at washings. We have a biorepository for that. I have a few different ctDNA studies because that's a strong area of interest of my own. And so that includes our own studies as well as trials sponsored by companies. But again, we're trying to really think about what we know now versus what we can learn. And I just, again, this is sort of the end of our day. I want to thank everybody for attending. On behalf of myself, Dr. Mogal, Dr. Sharib, please do fill out that feedback form that, again, was put in the chat box. We'll stay on a little bit longer to answer anything that might have come up in the Q&A, but we just so greatly appreciate your attendance. We hope that this was informative for you. And if there's things that we can do to be helpful, please do not hesitate to let us know, either as part of this webinar or maybe as part of a future clinical visit, if that makes sense. So thanks, everybody.
And one last comment to piggyback off what Dr. Cohen said. We really want to thank Ritu Shriyan, who is one of our events managers at Fred Hutch, for putting on this event and for partnering with us every year through thick and thin. And as you can imagine, getting all of this organized and put up is challenging. So Ritu, thank you so much. And I know we can't applaud in person, but a big round of virtual applause to you for all that you do for us and helping us put this important event on every year. Thank you so much. As Dr. Cohen mentioned, we'll be on for a few minutes. Please feel free to put up your questions. The advantage is that everybody then gets to see the answers if they're in the chat.